Okay, so welcome everybody to Friday's intensive care medicine teaching. So for those of you that don't know me, I'm Ricky Bell. I'm one of the intensive care consultants and nephrologists over at Leicester General. So today's topic is going to be on vasculitis. It's going to be presented by Dr. Pete Topham, who you can hopefully see in the top corner of your screen. And really, without sort of further ado, Pete, if you'd like to take over.
Great, thanks very much, Ricky. Right, welcome everybody. So I was asked to talk about vasculitis, I think primarily because there's been a few people on the intensive care units recently with difficult vasculitis, and because of that, I think a bit of additional knowledge was sought. So hopefully we'll be able to provide that today. So I'm very happy to be interrupted through the whole afternoon. I'm not going to make it hugely interactive, but please interrupt if there's anything that's a bit unclear or if you have any questions about what I'm talking about. So I guess the first thing is, why is vasculitis relevant to the intensive care settings? So the two commonest manifestations of vasculitis that you will likely come across in an intensive care setting would be related to lung involvement. So this just shows some issues related to the lung hemorrhage that patients with vasculitis can get. So they typically present with hemoptysis, which is usually frank, a chest X-ray that shows diffuse alveolar shadowing. Now, clearly this has a broad differential. This clearly could be fluid, it could be infection, but in the correct context, when you see a chest X-ray like that, you always need to think about diffuse alveolar hemorrhage, for which there are a number of different potential causes. CT scan just shows the same thing with alveolar shadowing. And the important thing to just know about the radiology here is that there is nothing on either chest X-ray or CT that is specific for lung hemorrhage. There is always a broad differential. The radiologists will mention lung hemorrhage if in the clinical information you give them vasculitis is raised, but there is nothing specific about the radiology that tells you that it's definitely hemorrhage. The second situation that you will likely come across in intensive care setting is renal failure and the need for continuous filtration. So this clearly is a manifestation of renal involvement with vasculitis, and I know that Ricky next week is talking about acute kidney injury, so I'm not going to go in much detail today about how you evaluate patients with acute kidney injury, other than just to realise that vasculitis is one of the potential explanations for acute kidney injury that you might see on the intensive care unit. Clearly, the vast majority of people will have acute tubular necrosis or pre-renal causes, but it's always important to think about other differentials. The question, therefore, is what is vasculitis and why is it bad for you? So this just shows the pathology just to demonstrate what happens. This is a cutaneous arteriole showing that you have leukocyte infiltration initially in the outside of the vessel, and then that inflammation penetrates the vessel, causes the vessel wall to become disrupted, and eventually you get thrombus formation within the lumen, which clearly prevents blood flow downstream of that. Now, the cutaneous manifestation of this is the classic vasculitic rash, and these areas on the skin are related to extravasation of blood from the blood vessels, and also with more extreme forms of the disease, you get ischemic and potentially necrotic areas in the skin because of damage to the blood vessels. Now, that process will occur in any organ that's affected by vasculitis. So that same process of damaging blood vessels will occur in any organ, and clearly, if it's severe enough, will cause organ dysfunction. So as I've alluded to, it's an inflammation of blood vessels. It is a multi-system disease, so any organ that you can think of can be affected by vasculitis, but it typically involves the skin, joints, kidneys, lungs, and the ENT system. So those are the commonest involved. Every person with vasculitis is different. Their pattern of disease tends to be very different from the next person. And the outcome for the patient really depends on the organ involvement, as you might imagine. And as I'll show you a bit later, the treatment of vasculitis tends to be adjusted to the prevalent pattern of disease in the individual patient. So any talk of vasculitis invariably uses this picture. So this just shows the overall classification of vasculitic diseases, which is based on the size of the blood vessel that's affected. So down here you have the two large vessel vasculitides that affects large arteries, distributing arteries, and also the larger arterioles. So the two conditions there are giant cell arteritis and Takayasu's arteritis, which are mainly the same diseases, differentiated by the age at which they present. So above the age of 40, it's typically called giant cell arteritis, less than 40 is Takayasu's. Then you've got medium vessel disease with Kawasaki disease predominantly affecting young children. In adults, it's predominantly polyarteritis nodosa, but it's a very rare disease and not one that I'm going to particularly focus on today. More common, although still rare, are the small vessel vasculitides, which can broadly be characterized into the anchor-associated vasculitides and those that are associated with immune complex deposition. So you've got antiglomerular basement membrane disease, vasculitis related to cryoglobulins, IgA vasculitis, which previously was known as Henoch-Schönlein purpura, and very rarely this hypocomplementemic urticarial vasculitis. So of all of those, the small vessel, the anchor-associated vasculitis tends to be the commonest and tends to be the conditions that result in the problems that will present to the intensivist. So for the rest of the talk, I'm going to predominantly focus on those. So there are, broadly speaking, 4 different forms of anchor-associated vasculitis. Previously, there was a condition called Wegener's granulomatosis, which you've probably heard of. Over the last few years, that's been renamed to granulomatosis with polyangiitis, or GPA. As you know, there's a move away from named diseases, and Wegener's cause wasn't helped by the fact that he turned out to be a Nazi sympathizer, so that his name went out very, very quickly. The second condition is microscopic polyangiitis. There is a condition that was previously known as Churg-Strauss syndrome, which is now known as eosinophilic granulomatosis with polyangiitis, or EGPA. And the final condition is renal limited vasculitis. So this is renal disease with all the hallmarks of a small vessel vasculitic process without any evidence of organ involvement outside of the kidneys. So it's an autoimmune disease of unknown cause. It predominantly affects older people. And as you can see here, you've got GPA in the blue bars, microscopic polyangiitis in the green bars. And as you get older, going from left to right, the incidence increases. It is important to note, however, that even if you get to down to ages of 15, GPA cases will still be seen, and we've certainly had a number of very young people with severe GPA coming through the intensive care units over the last few years. And you may recall a patient earlier this year on the ITU at Glenfield who was on ECMO for some time and unfortunately died as a consequence of his disease. So just because somebody is young, do not discount anchor-associated vasculitis as a cause of their disease. The male-female spread is fairly equal. It's predominantly a disease of white people. It's rare. The incidence is about 20 per million per year. So roughly in this area, we'll see perhaps 20 new cases per year, and the prevalence is about 10 times that. It's a bad disease to have. Without treatment, there's an 82% mortality at a year. And as the name suggests, the condition tends to be associated with the presence of these antibodies targeted against anti-neutrophil cytoplasm antigens. It's worth just talking about how these conditions present, because understanding how these patients will present will help you make the diagnosis. So one of the most important features is these background constitutional symptoms. And the vast majority of patients we see with ANCA-associated vasculitis in retrospect have been unwell for weeks, probably months before the diagnosis is actually made. And the problem is those symptoms are very vague and non-specific. So they may just generally feel under the weather, they lose their appetite, they have vague joint pains, muscle pains. They usually lose weight, they may have fever as the condition progresses. And in the older population, we see a significant number of people who have been labelled as having polymyalgia rheumatica because of these symptoms, and have usually been started on steroids, which then masks the progression of the disease. It's unusual to have a new presentation of ANCA-associated vasculitis without this prodrome. ENT and pulmonary disease is very common in GPA, less common in MPA. Nasal crusting and bloody nasal discharge is very common. Mouth and nose ulcers and a variety of different ear involvements can happen. In terms of the lungs, cough, breathlessness, and obviously worrying is when they start to cough up bloody phlegm, which indicates the development of lung hemorrhage. Kidney involvement is incredibly common, which is why we as nephrologists get involved in its management. So most patients with ANCA-associated vasculitis will have some form of renal involvement by 2 years after presentation. And that can vary enormously from very aggressive renal disease causing renal failure to the presence of non-visible hematuria. Nonetheless, it's worth always dip testing the urine, because even if there's just non-visible hematuria and the diagnosis is unclear, a kidney biopsy may establish the diagnosis. And so we sometimes will biopsy patients with a possibility of ANCA-associated vasculitis with relatively modest renal abnormalities to try and secure the diagnosis. So always dip test the urine. I've shown you some of the skin presentations with the classic vasculitic rash, which is pathologically a leukocytoclastic angiitis, but there's a whole range of other skin presentations. The eye is affected in a bit less than half of patients. The commonest presentation is probably episcleritis or scleritis, but there's a whole range of other manifestations that can happen. Nervous system involvement is potentially very worrying. Mononeuritis multiplex is perhaps one of the commonest abnormalities that we see. You can have CNS mass lesions, which can be mistaken for brain tumours, and I'll show you an example of that in a moment. It can affect the GI tract and present as GI bleeding. Again, that can be life-threatening. Cardiac involvement is rare, but again, bad when it happens. And again, you can see involvement of the GU tract with involvement of the ureters, prostate, and also you can get inflammatory masses in a whole range of other organs as well. So the presentation can be very, very many and varied. So this is the classic nasal presentation of somebody with advanced GPA, showing the effects of destructive cartilage disease, showing saddle deformity of the nose. This is collapse of the nasal cartilage. This is somebody with episcleritis, the cutaneous skin rash, lung infiltrates, nodules on CT of the chest. And this is the pathological change you see on a kidney biopsy, and I'll come back to that in a moment. This just shows images from a couple of our patients. This is a patient with really nasty eye disease. So this is a kind of inflammatory mass in the rectal orbit with inflammation extending in front of the eye. He had this for years, very, very difficult to manage. Again, initially when this presented, there was concern that this was a malignant process. So he had a number of biopsies before the diagnosis was secured. And this is a patient with CNS involvement showing these two mass lesions in the frontal lobe. And again, this was his mode of presentation, and it took some time before the diagnosis was secured, including brain biopsies, which were undertaken. Oh, okay, so we've talked about GPA and MPA, and I guess the question is it important to make a difference, to differentiate between the two? Clinically, it's very difficult. The main difference between the two is the presence of granulomatous inflammation in GPA in contrast to MPA. The problem is that when you biopsy samples, you don't always see granulomas in patients with GPA, because possibly that's because of sampling error. And when we biopsy a kidney, it's very, very rare to see granulomas even in patients with GPA. They just tend not to happen in the kidney. Clinically, if you've got ENT or upper airway involvement, it favours GPA rather than MPA. If you've got upper airway and retroorbital masses, again, that tends to favour GPA. And if you've got cranial nerve entrapment syndromes, then again, that favours GPA. The question is, does it matter? And in terms of the patients you're likely to see when they're presenting with uncontrolled disease, it doesn't really matter, because the initial treatment is exactly the same. Later on, when you're coming to maintenance treatment, there is some differences that are important. So, for instance, GPA is much more likely to relapse than MPA. So the relapse risk from GPA is up to 80% compared to up to 35% for MPA. So you're much more likely to consider withdrawal of immunosuppression in patients with MPA rather than GPA. And GPA is much more likely to be associated with upper airway disease and ENT disease that can be very, very problematic. So, for instance, it can cause tracheal stenosis, which may require a tracheostomy. As I've shown you, it can cause destructive damage to the nasal cartilage, which may require additional treatment as well. So patients with GPA just need to be watched a bit more carefully for upper airway and ENT disease. What it actually boils down to, however, is not really the clinical diagnosis of GPA and MPA. All the differences between relapse risk and the risk of complications in the longer term is accounted for by the different or the antibody specificity. So that really is determined by whether your anchor antibodies target proteinase 3 or whether they target myeloperoxidase, and I'll talk about that in just a second. So when we're testing for anchor, the screening test is indirect immunofluorescence. So your anchor test is done in this way. So they take a slide with neutrophils on. So this just shows the neutrophils here, and they do indirect immunofluorescence. And you come up with two patterns of staining. The first is the C anchor or classical anchor, which describes a diffuse cytoplasmic pattern of staining. So this implies that the antigen targeted by anchor is diffusely found in the neutrophil cytoplasm. The vast majority of those patients with a C anchor pattern, the anchor specificity is against an antigen called proteinase 3 or PR3. The second pattern is P anchor or the perinuclear pattern, where the intensity of staining is particularly around the nucleus. And again, in the vast majority of cases, patients with P anchor staining are positive for have antibodies targeted against an antigen called myeloperoxidase. And so what the laboratory will do when you do your screening test, if the indirect immunofluorescence is positive, they will do a specific test using an ELISA, using purified specific antigens to determine whether the anchor is associated with PR3 or MPO. So the disease association. So most people with active GPA have detectable anchor. The majority of those are targeted against anti-PR3 or are anti-PR3 antibodies. The remainder are MPO antibodies. The key thing is that a significant number of people with vasculitis will be anchor negative. And particularly if you've got organ-limited disease, there's a high chance that you will be anchor negative. So up to 40% of patients with mainly ENT disease will be anchor negative. In terms of MPA, again, 90% of people with active disease will be positive, and the majority, 60% or so, will have antibodies against MPO, and the remainder of those with anchor positivity will be targeted against PR3. If you've got a positive indirect immunofluorescence and you have an ELISA which either identifies an MPO or a PR3, you've got an 88% chance of having small vessel vasculitis. So there's quite a good combination of tests to help diagnose the disease. The problem is, as I've said, patients with vasculitis who are negative for anchor. So that accounts for up to 10% of people with GPA will be ANCA negative, and up to 30% of patients with MPA will be ANCA negative. So therefore, the suspicion of the disease being there has to be there. So just don't discount a negative ANCA and assume that that rules out the presence of vasculitis. So this is a very busy slide, and I apologize for it, but it just really makes the point about whether ANCA causes vasculitis. This has been an area of significant debate over years, but the current consensus is that ANCA is at least in part pathogenic, and it does a variety of roles. So basically, when you have a vasculitic process, there's a number of stages. First of all, you have to prime the neutrophils, and that's predominantly done by release of cytokines. The release of cytokines then translocates the ANCA antigens, either the PR3 or the MPO, to the surface of neutrophils. If you have ANCA in the circulation, that then binds. You then get complement activation. C5a is produced. That further primes the neutrophils, causes them to activate, translocates to the endothelium, translocates across the endothelium. You end up with necrosis, fibrinoid necrosis within the wall of the blood vessel. And again, you get release of PR3 and MPO, which binds to macrophages. And again, when you bind ANCA to those, that activates the macrophages, which works in concert with neutrophils to cause the inflammation. So there's reasonable evidence at the moment that ANCA actually is pathogenic, which helps to think about some of the treatments that we use, which I'll talk about in a moment. So there are other things that can be associated with vasculitis. Infection appears to be important. So clinically, we see that patients with vasculitis tend to come in waves. So we go sometimes months without seeing somebody with vasculitis, and then we'll see a few patients presenting in a fairly short period of time, suggesting some environmental trigger. So there is an association between Staph aureus carriage in the nasal mucosa and vasculitis. So 65% of people with GPA compared to 20% of controls will have nasal carriage of Staph aureus. And the presence of Staph aureus is strongly associated with relapse in GPA. So if you go from being negative for Staph aureus to positive, that is strongly associated with the relapse in GPA, suggesting a possible causative, not causative, but a priming role. The other piece of evidence for the role of infection are the presence of antibodies against this bacterial adhesion molecule called LAMP. So these have been associated with patients with ANCA-associated vasculitis, and it's probably a result of what's called molecular mimicry. So you have infection with particular bacteria that contain this particular antigen, you generate antibodies against it, and then there is cross-reactivity with antigens within human neutrophils, and it then primes neutrophils in the same way that ANCA does and can be a mediator of disease. So there's reasonable evidence that infection can at least be a trigger for vasculitis. There are genetic associations, so PR3 ANCA positivity is associated with abnormalities of the PR3 gene, the alpha-1 antitrypsin gene, and is associated with the HLA-DP. In contrast, MPO ANCA positivity is associated with HLA-DQ. So it implies a genetic predisposition to ANCA-associated vasculitis, and it also provides evidence that MPA and GPA are actually distinct genetic diseases. There's a very weak familial risk with ANCA-associated vasculitis, so your risk of ANCA-associated vasculitis increases by 1.5-fold if you have a first-degree relative with vasculitis, implying some kind of genetic predisposition. Drugs have been associated with it, so hydralazine, minocycline, and all the others I've listed there have been temporally associated with ANCA seroconversion. As I said, the temporal relationship has been demonstrated, but cause and effect hasn't been established. But it might be that drugs have a role in priming ANCA production and therefore might be causative in some patients. And finally, there are environmental exposure risk. So if you're exposed to silica, you've got 3 times the risk of ANCA-associated vasculitis. And if you're involved in farming or keeping livestock, then again, your risk is increased to a modest extent, again, suggesting the presence of environmental triggers. So in terms of diagnosis, the most important thing is having a clinical suspicion. So somebody who presents with either respiratory problems that don't necessarily fulfill a clear diagnostic pattern, or patients with acute kidney injury, always consider ANCA-associated vasculitis. Go back through the backgrounds, look out for any other symptoms, signs of things that could go along with ANCA-associated vasculitis, and really probe very hard for evidence of a prodromal illness going back weeks or months. Obviously, look out for the classic physical findings. If there's a vasculitic rash, it makes it blindingly obvious. Do a neurological exam, look at the eyes, look at the nasal passages. Dipstick urinalysis is absolutely critical. Any patient who's acutely unwell, always dip test the urine for blood and protein. If you've got blood and protein in the absence of infection, it implies glomerular inflammation until proven otherwise. Usually patients with active ANCA-associated vasculitis, they may have impaired kidney function, they're often anemic, and if you've got lung hemorrhage, they may be significantly anemic, and obviously they have a diffuse inflammatory response characterized by a raised CRP. Again, anybody without a clear-cut cause for their illness, always do an immunological profile, and clearly the key in this case is asking for an ANCA test, but also do other immunological tests, ANA, double-stranded DNA, serum protein electrophoresis. Ideally, before we give potentially toxic treatment, we like to get a tissue diagnosis to be absolutely sure that we're treating the right thing. And there's a variety of tissues that you can biopsy. Skin is relatively easy. The problem with that is that the skin changes are relatively non-specific. You'll come up with a leukocytoclastic vasculitis, which can be seen in a whole variety of different things. Nasal biopsy, again, if you can get an ENT surgeon, they're relatively straightforward to do, but again, not always diagnostic. You don't always see granulomas, and often you just see non-specific inflammation. Lung biopsy, again, helpful, but dangerous, and certainly somebody with respiratory failure is not going to get a lung biopsy done. And so very often it boils down to doing a kidney biopsy, which isn't without risk, but it's a relatively straightforward procedure. And it's done under local anaesthetic with a biopsy needle. This just shows the needle going into the kidney on ultrasound. This is the kind of tissue you pull out. This is about 2 centimeters long, and you can see the glomeruli under a kind of dissecting microscope there. And as I've shown you already, this is the hallmark abnormality that you see in ANCA-associated vasculitis. So this is a normal glomerulus. This is a vasculitic glomerulus, and you can see it's been replaced by this mass of inflammatory cells. So this is what's called crescentic glomerulonephritis, and you often see fibrin deposition within the glomerulus, which is indicative of necrosis. Again, the hallmark is that this is seen without the deposition of antibody and without deposition of complements, so it's so-called porcine immune. So you can send a kidney biopsy off to the laboratory, and they will return this together with indirect immunofluorescence very often the same day if you get it done early enough. And if you see that, this kind of change with a negative immunofluorescence, that's pretty much diagnostic of small vessel vasculitis and gives you reassurance that you're treating the right thing. Okay, so I just finally want to talk briefly about treatment of ANCA-associated vasculitis. So I've already alluded to that untreated, 82% of people will be dead within a year. And so all patients have to be considered for treatment. The treatment regimens are exactly the same for GPA and MPA as things stand at the moment. There are no treatments that are specific for each individual disease, which in a way makes it relatively straightforward. Most of the time you'll be involved in induction of remission of active disease, and obviously once you've induced remission, then there's a different phase where you're maintaining remission. The drugs that we use are listed here. So this just shows the drugs in terms of increasing side effects as you go up the screen, increasing side effects. And the drugs we tend to use first off would be cyclophosphamide, steroids, and rituximab. But these are the drugs that can be used along the way. A number of drugs are being developed as we speak, and these are mainly inhibitors of complement components. And I think the next big thing therapeutically for inflammatory disease are going to be these complement inhibitors, which we're starting to use in a number of different conditions now. So in terms of treatment, it's all risk stratified depending on how severe the disease is. So if you have organ or life-threatening features at presentation, you clearly need to treat aggressively. So if you've got active glomerulonephritis, diffuse alveolar hemorrhage, cerebral involvement, neuropathic disease, orbital tumours, GI bleed, or cardiac involvement, you need to treat aggressively, because without aggressive treatment, these potentially are life-limiting. And you need to come in with aggressive treatment with rituximab, cyclophosphamide, and glucocorticoids. In addition to that, you might consider plasma exchange, and I'm going to talk about that in a bit of detail in a second, because you've probably seen people on the intensive care unit being plasma exchange for ANCA-associated vasculitis, but that is an area of significant contention at the moment. You're probably not going to see people with less significant disease. However, if they don't have organ or life-threatening disease, they typically are treated with methotrexate with the other treatments in reserve if they're not suitable for that. So for induction of treatment, we have two options available: cyclophosphamide versus rituximab. I'm not going to labor on this point, but we actually do have some RCTs to guide what we do here. There are two head-to-head trials in induction of ANCA-associated vasculitis comparing cyclophosphamide and rituximab. I won't go through the details. The bottom line is that for patients with new presentation, rituximab and cyclophosphamide are basically equivalent. This study suggested that treatment of patients with relapsing disease, rituximab might be superior to cyclophosphamide. The second study essentially showed the same thing, head-to-head comparison of rituximab with cyclophosphamide, and out to about 2 and a bit years, the proportion of patients without a relapse of disease was essentially identical between the two groups. And so in terms of efficacy, cyclophosphamide and rituximab is largely interchangeable. So NICE have had an opinion on this, primarily because rituximab is expensive, cyclophosphamide is cheap. So for most patients, we will use cyclophosphamide, and the times that you're allowed to use rituximab are basically those circumstances are listed here. So if you've had previous cyclophosphamide and if you had any more exposure, that would take you above the maximum cumulative dose. If it's contraindicated or not tolerated for any reason, you can use rituximab. Cyclophosphamide will affect fertility, and so in people of childbearing age, we would tend to use rituximab. If you're non-responsive to cyclophosphamide, again, you can use rituximab. And if you've had previous urothelial malignancy, you can use rituximab because of the risk of bladder cancer associated with cyclophosphamide. So we still work generally to that guidance. Corticosteroids are an integral part of the treatment. High-dose steroids are standard of care, but there is no RCT evidence to support that use. It's all anecdotal or cohort studies. For severe disease, so acute kidney injury or lung disease, we would give methylprednisolone, either 500 to 1,000 milligrams daily for 3 doses, and then we would give oral steroids starting at 1 milligram per kilogram per day. The problem with steroids is that the infective complications that occur during treatment with ANCA-associated vasculitis, they predominantly correlate with the glucocorticoid dose rather than whether you have rituximab, cyclophosphamide. The vast majority of infective complications are associated with glucocorticoids. And so there is a move to try and minimize exposure to glucocorticoids. And we now have a trial that helps us know what to do with that. So this is a trial that was published last year in the New England Journal of Medicine. It's a huge trial in terms of vasculitis. It included over 600 patients. It was a 2x2 factorial design, so it compared two things, either plasma exchange or no plasma exchange, and a standard regimen of steroids versus a reduced regimen of steroids. So straightforward inclusion criteria, either new or relapsing ANCA-associated vasculitis. They had to be ANCA positive, and they either had to have renal involvement with a GFR of less than 50 mils a minute, or lung involvement with evidence of diffuse alveolar hemorrhage. So as I said, there were 606 patients who got to the end of the trial. Most were MPA positive. A small number had relapsing disease, probable relapsing disease. A third of the patients had a creatinine above 500 or on dialysis. Only 9% had severe lung hemorrhage. So that just has to be taken into account in terms of interpreting the results at the end. Almost all had renal involvement, and the majority of patients had cyclophosphamide rather than rituximab. So this just compares the two steroid doses. This is standard, so you start at 1 milligram per kilogram per day for 2 weeks, and then a gradual taper. This is the reduced dose regimen, so again starts at milligram per kilogram a day for a week, and then basically it halves the dose after the end of the first week. And the bottom line is that over a 6-year period of follow-up, there is absolutely no difference between the primary endpoint, which was death or end-stage kidney disease, between either the standard or the reduced dose. So that has changed practice. We now use half the dose of steroids that we used to do. The important part of that is that the risk of serious infection by 1 year was significantly reduced in the reduced dose regimen. So that kind of supports the notion that glucocorticoids are relevant in terms of infection complications. So that is something that has changed. The thing that is much more controversial is plasma exchange. So the principle behind plasma exchange is that it removes potentially pathogenic antibodies, as well as potential mediators of inflammation and coagulation. And we've been using plasma exchange in ANCA-associated vasculitis for more than 20 years. And we've reserved it previously for patients with severe renal failure. So broadly speaking, a creatinine above 360 or dialysis dependency, or if they've had lung hemorrhage. And we use that in combination with steroids and cyclophosphamide rituximab. But since the PEXIVAS trial, the use has been much more controversial, and I'll come back to that in a second. So there are two ways of plasma exchanging. The way that you'll see on the intensive care unit uses membrane filtration, which is a process very similar to dialysis. You take blood from the patient, you pump it through a filter, and you return it to the patient. In contrast to a dialysis filter, the holes in the plasma filter are much bigger, so they're big enough to let albumin across, and they're big enough to let antibodies and immune complexes across. And you can choose membranes with different pore sizes, so some will just let IgG across, some will let IgM across. Obviously then cells, the cellular components are left within the blood compartment, and then you return pooled whole plasma and return it to the patient. And obviously the notion here is you're removing potentially pathogenic mediators of the disease. The other form of plasma exchange is what the hematologists tend to use, which is a centrifugal technique. So the blood is taken from the patient, it's put in a centrifugal device, and essentially the plasma is spun off, the cells are retained, pooled plasma is returned, and then the blood's returned to the patient. Broadly speaking, they're equivalently effective. Obviously, because you've got a membrane with specific size pores here, in principle, because you're moving all of the plasma in this process here, you will be removing more of the higher molecular weight proteins than you are with plasma filtration. All of the studies, however, looking at plasma exchange in ANCA-associated vasculitis have tended to use membrane filtration, however. The other important thing to recognise is in order to do plasma exchange, you have to anticoagulate the patient. And so if you have somebody with diffuse alveolar hemorrhage, that clearly might be counterproductive. And with regional anticoagulation, that helps, but you just need to be very, very careful about the effects of plasma exchange on the coagulation. The other thing to remember is that you will be removing coagulation components, and so we will usually finish off the plasma exchange using fresh frozen plasma, or alternatively, if there's a very, very high bleeding risk, the whole of the plasma that you're returning can be FFP to properly prevent the risk of worsening any alveolar hemorrhage. But you just need to bear that in mind when you prescribe the plasma exchange. So up until last year, this was the kind of data we worked on. This is a meta-analysis of a number of different studies of plasma exchange. You can see all of these studies amount to about 387 patients. This is the overall result, which just about favours plasma exchange in patients with severe active renal disease, with the primary outcome being end-stage kidney disease and death. So that's been the basis of plasma exchange that we've done in the past. This is the outcome of the Pexivas trial, again out to 6 years, and you can see that the plasma exchange versus no plasma exchange group, the outcome in terms of death or end-stage kidney disease is identical. So that kind of took the wind out of our sails a little bit, and for a period of time we kind of relaxed a little bit in terms of plasma exchange. This is subgroup analysis looking at those patients in the study with lung hemorrhage. And you can see there is a trend towards favouring Plex in terms of death in patients with lung hemorrhage, but because of numbers being relatively small, it wasn't statistically significant, but there is a trend towards it. The key thing to remember is that you have to think about the patient population in the study. There are a very small number of cases of severe diffuse alveolar hemorrhage, probably less than 50. And you have to consider how the study was designed, and it's always important to do this with any study that you're reviewing. It is perfectly possible that patients with severe diffuse alveolar hemorrhage may not have been enrolled in the study. Clinicians looking after them may have been convinced that they needed plasma exchange, and they were not willing to take the risk of patients being randomized to the no Plex arm of the study, and therefore they didn't include them in the study. And that might be why there's a relatively small numbers of diffuse alveolar hemorrhage. So you just need to bear that in mind in terms of interpreting the study. Subsequent to Pexivas being published, there is now unpublished meta-analysis which provides some support for ongoing use of plasma exchange in patients with acute kidney injury. So it's been shown that in this meta-analysis that if you've got a creatinine more than 500 or you're on dialysis, then your absolute risk reduction of having plasma exchange versus no plasma exchange is 15.2%, and that is a risk of end-stage kidney disease. Oh, sorry, I don't know what I did there. So that hasn't yet been published, so it hasn't yet entered the public domain, but the role of Plex is a little bit controversial at the moment. We're certainly using it less often than we did before. We would still definitely use it if the ANCA-associated vasculitic patient also has antibodies against anti-GBM disease, which does happen. We would probably still use it for patients with severe lung hemorrhage, certainly those patients who required respiratory support. We would, I think, still use plasma exchange. Having said that, there are centres in the UK who are not doing that anymore. So it is really very contentious at the moment. We might also use it still for patients with severe renal disease, certainly if the creatinine is above 500 and if on biopsy they've got severe but very fresh acute changes on the biopsy. If there's more chronic changes, then that risk-benefit balance probably changes a little bit. So just to summarise the treatment, all patients will get glucocorticoids. Patients will either get cyclophosphamide or rituximab. Plasma exchange, definitely if you've got anti-GBM positivity as well. possibly with lung hemorrhage, and very possibly with severe renal disease. The other thing just to remember is that we always give adjunctive treatment as well. With all of these treatment, there's a risk of opportunistic infection, so we always give an anti-pneumocystis drug, typically cotrimoxazole, and we also give antifungal as well, in the form of fluconazole typically. Gastroprotection is important, and obviously bone protection with the amount of steroids that we're using is also important. So just about done. So just to summarize, ANCA-associated vasculitis is life-threatening, it's multi-system. The symptoms and signs and severity will vary enormously. Effective treatment is available, and we do have some evidence base for it, but that evidence base is a little bit hard to interpret, unfortunately, at the moment. The most important thing in looking after such patients is making the diagnosis in the first case. So always consider it in patients with unusual lung disease or acute kidney injury. With the treatment that I've talked about, remission usually is seen in about 90% of patients. But in spite of that, the outcome isn't ideal. So the mortality is still about 20 to 30% at 5 years. 25% of patients will end up with end-stage kidney disease. And because of the treatment, there's a significant increase in cancer risk in the longer term as well. So that's all I have to say, and I'll be more than happy to take any questions that you may have.
Thank you very much, Pete. That's been brilliant. Does anybody have any questions or comments they would like to ask? So I got called away in the middle of that, so I might possibly be, repeating something. But certainly for me, Pete, it feels like it always feels like this is one of those diagnoses that, although it's rare, I think as you said just before I left, it gets missed quite often. And I think often, the sort of classic story of the patient with a vasculitic rash and acute kidney injury is kind of, well, although it's classic, I don't tend to see that much of it. It tends to be kind of the patients that I think of that kind of have those vague sort of constitutional symptoms, then presenting with an AKI, and I think, they often get missed, really. I don't know what your thoughts are on that.
Yeah, absolutely. So as I kind of alluded to earlier, most patients that we see, have had a prodrome. They've seen their GP on sometimes a regular basis, and it's a rare disease, and the symptoms that they have are usually attributable to other conditions, viral illnesses, polymyalgia, as I said. So I think the key is clarifying, or just taking the correct history to get that prodromal illness, and if then things change, either with respiratory disease or acute kidney injury, that's usually the point that the penny drops and the diagnosis is made. Having the ANCA antibody testing so widely available now makes the whole process so much easier. Pretty much, if you get the test off in the morning, you get the result back same day. So it really just boils down to considering it as a diagnosis and getting the appropriate test off. And even if the majority of the tests that you send off come back negative, that's, I think, fine in my view. If somebody is sick enough to get into hospital with acute kidney injury with that kind of prodrome, then an ANCA test should be done together with the other immunological tests. And it also the dipping the urine is also, it just I think supports the need to do that, really, because an abnormal urine in this context is glomerular disease until proven otherwise.
Okay, Alexander, I think you have your hand up first. You got a question?
Hi, hi Ricky, it's Kevin here, one of the IT pharmacists.
Hello.
Hi there. My question was relating to the rituximab and cyclophosphamide. I was just wondering if the RCTs compared the side effect profile of those two agents as well, to see if there's any difference. And if you had a choice, and if they both cost the same, would you use rituximab every single time?
Yeah, absolutely. In the short term, the side effect profile probably isn't that different. Most people who have cyclophosphamide are absolutely fine, and I've not gone through any detail. So most of the time we give cyclophosphamide intravenously now. Until a few years ago, we gave it orally. There's good evidence that giving intravenously reduces the risk of infection during the time that you're having it. And to be perfectly honest, in the short term, it's unusual to get cyclophosphamide-related problems. The infection risk is probably comparable to what you see with rituximab. Always the concern with rituximab is obviously once you've given it, it's there for 6 months or so. Whereas with cyclophosphamide, you're given the injections every 2-3 weeks. So it's a bit easier to reverse the effects of cyclophosphamide. But broadly speaking, the side effect profile in the short term is the same. In the longer term, the issue with cyclophosphamide relates to cancer risk, which is higher than it is for rituximab. The other big issue is fertility. Clearly with the younger patients, and I think it's probably almost indefensible now to cause infertility by using cyclophosphamide when you could have used rituximab. So generally speaking, people of childbearing age, we would use rituximab rather than cyclophosphamide. And if it were me, I'd have rituximab.
Thank you.
Whale, you got a question?
Hi, my question, actually, usually this patient presents with acute phase like acute kidney injury, so gradual deterioration of creatinine, and then they build up to the degree they came edematous, shortness of breath. Sometimes they require respiratory support, and usually the support for them is either CRRT at intensive care or regular hemodialysis, sometimes and plus also the methylprednisolone. My question regarding cyclophosphamide or rituximab, do we start them in acute phase as well, or we start them later on?
So essentially, the sooner you get treatment in, the better. So both will take a couple of weeks before they're maximally effective. So we generally, the reason for giving the methylpred is that the effect is very rapid. But the sooner you get the cyclophosphamide or the rituximab in, the better, because then that coincides as the prednisolone doses started to be reduced. Clearly, it's important that you've firmed up the diagnosis before you give the rituximab. So the methylpred is quite a useful holding measure until you've firmed up the diagnosis. But as soon as you're clear, and I guess the other issue is ensuring that there's no infective problem that needs to be dealt with first, then you should get the cyclophosphamide and the rituximab going as soon as possible. So the other thing you've kind of raised an important point really is that the X-ray I showed you first thing with the lung infiltrates. In somebody with acute kidney injury, there's clearly a huge differential for that, and it might just be that they're very volume overloaded and they've got pulmonary edema. So you always need to think about lung hemorrhage, but there is a clear differential for those appearances. And so inevitably we would, if they're dialysis, we'd either diurese them or we'd filter them and get fluid off. And we would give them broad spectrum antibiotics to cover the other differentials for that chest X-ray appearance.
Thank you.
Any other questions from anyone else? Otherwise, I think we'll probably get on with the journal club part of things. Pete, any sort of closing comments? Anything else you want to say?
No, it's absolutely fine. So I hope that's been okay. Thanks very much.
That's been brilliant. Thank you again, Pete. Thank you.
Cheers. Thanks a lot. Bye-bye.
My paper to present today is the MAGPIE trial, which is a fairly well-known trial from the early 2000s. So the full name of it is Do Women with Preeclampsia and the Baby benefit from magnesium sulfite, the MAGPIE trial, and the MAGPIE trial being magnesium sulfite prevention of eclampsia. It said it was published in the Lancet in 2002, so it's now getting to be an older trial. It's a very large multinational trial, initially run with pilots in South Africa, main study running from about 98 to 2001. It was stopped earlier, and the overall coordination was in Oxford. Just to give you an idea of kind of how many centres were involved, this is the list of authors as part of the paper, so it's very, very large. So a bit of background, and I've tried to do this kind of from a 2002 perspective. Obviously, preeclampsia is and still is a systemic disorder affecting 2 to 8% of pregnancies, and it is involved with about 15% of direct maternal deaths, and 2/3 have also got involvement with the preeclampsia. There are higher rates of maternal death overall, and in particular with eclampsia in developing countries, which is something that this trial was trying to have a look at. And later on, when we get to recruitment, we'll see how much of an impact developing countries had on the trial. At the time then, anticonvulsant drugs were still also used in addition to magnesium to try and treat eclampsia and to try and treat preeclampsia. And there was a Cochrane review done just prior to the beginning of this trial, identifying magnesium as a possible promising anti-epileptic device, anti-seizure device compared with the other anticonvulsant drugs. There wasn't much in the literature at this time about risk reduction, other effects on kind of other outcomes, morbidity, mortality, fetal morbidity and mortality, and when if the benefits outweighed the risks, and also the side effect profiles. And the final thing that they mentioned is the mechanism of action of magnesium in eclampsia. It was then poorly understood and is still poorly understood. It kind of seems to have been a thought of it decreases some inflammatory mediators, lots of other kind of soluble inflammatory markers throughout, and could also potentially block some signal transmissions in the brain. It's still not fully well understood. With any paper, I think having a good clinical question to start off with is a good kind of launching point, and this one's in the title of the paper really. Later on in their introduction, they kind of mentioned a bit more specific, which is to try and see if both women and their children do better if they're given magnesium rather than placebo, and whether the treatment started before anti-delivery, irrespective of anything else, actually helps. There was also a small mention about trying to develop an understanding at which point magnesium sulfate would help in preeclampsia, whether, with early signs with a small amount of protein, full on to, imminent preeclampsia with signs of imminent preeclampsia, such as flashing lights, etc., etc. So getting onto the trial design and kind of making sure it's set up to answer the clinical question. So obviously preeclamptic women were included, and that's the target for this study. It wasn't looking at any other kind of seizure activity. 33 countries involved, 175 actual hospitals in a variety of countries. I don't have the full list, but it is in the paper. It was a double-blinded, parallel group, randomized, controlled trial. And the primary outcomes will come into a second, but mostly were looking at the reduction in eclampsia, as well as death of baby and death of women. Initial sample size was 1,400, later reduced down to about, I think in all they got about 12,000 or so, but they did stop early, and it was an intention to treat with follow-up until discharge from the hospital. And I think there are some papers later on looking at further follow-ups on those of the actual of the babies delivered, which we'll come to later on. Next slide. So, yeah, this is the assumptions that they made to begin with for their power calculations. Essentially, they thought the risk of convulsions was about 1%, and that's why they wanted 14,000, which is obviously a large data set. Turned out that as they were doing this, the overall risk was about 1.2, so they lowered that power calculation down. I've put this mostly in here because they initially set off saying that if there was proof beyond a reasonable doubt that magnesium sulfate was either clearly indicated, clearly contraindicated, or there would be no difference. And they stated it as having a difference of at least three kind of standard deviations. In at least one of the primary outcomes, they would stop. And after about the review of 8,500 women, that was the case, that they found a statistical difference so they did stop the trial early. And I think although they found that primary outcomes, some of their other outcomes may have been slightly affected by it. So getting onto the outcomes, and there are quite a few from this paper. Like I mentioned, main one is the eclampsia, death of baby before discharge, and then a composite measures of serious maternal morbidity, which are kind of part of the secondary outcomes on that side. Those being respiratory depression at the time, the side effects of magnesium, and one of the big worries about magnesium was the thought of respiratory depression and respiratory arrest. There was also mention of hypotension, given as well that oftentimes these patients are treated with antihypertensives, and other maternal morbidity things that you can see there. The other secondary outcomes they were looking at were signs of toxicity and other side effects of magnesium, routes of injection, those kind of things. So there was even more outcomes after this as well, and this was kind of measuring the maternal health services and the neonatal health services resources. Well, of course, some of these resources are not available in all the hospitals that they were looking at, which did limit their outcomes. And although they've mentioned this in their outcomes section, they didn't really comment on their results or their discussion later on. So it's kind of, I think, an ideal outcome that they didn't really manage to achieve. So population-wise, like I've mentioned, it is eclamptic ladies, both pre and post-delivery. And if it was pre-delivery, they're then also having a look at the neonates born after delivery. So obviously for that, you're going to have blood pressure that's going to be high, proteinuria. And then the other eligibility criteria was a clinical uncertainty about whether magnesium sulfate would be beneficial. And I think this crops up later on as one of the weaknesses of this, because if you've got a clinician who is certain about whether or not magnesium sulfate would be beneficial, they either would or wouldn't include them, but those people would not be included in the data set. That could potentially skew their outcomes. Like I said, they're recruited irrespective of previous anticonvulsants, and if it was a singleton or multiple pregnancy. And most of the recruitment was done on the wards, but could be done either by the midwife or obstetrician, albeit I think all the patients were then reviewed by the obstetrician if they were involved prior to starting any treatment. Obviously, there's exclusion criteria, quite small set of exclusion criteria, and relatively straightforward ones. Any hypersensitivity, any hepatic coma with risk of renal failure, although oliguria and kind of a small degree of renal failure was tolerated, and then myasthenia gravis for the risk of weakness in limbs. As I mentioned, if you were oliguric, you could still be enrolled, but the volume of the treatment was halved for each dose, and as I mentioned before, I think the main thing to draw from this kind of inclusion and population criteria is that there was a large dependency on the clinician's belief about magnesium sulfate. And there may have been more people who are eligible but not recruited because of this. They then took more details as well and went on to subgroup analysis about their patients. So some of the correct characteristics they tracked were the severity of preeclampsia, whether or not it was imminent, gestational age, and I think they had a cutoff of about 34 weeks. If they'd had a previous anticonvulsant, and obviously whether they were, had yet to deliver already or already had delivered. They also then had a look at subgroup analysis based on the country of recruitment, perinatal mortality. So some of the examples, these are all taken from the trial itself. Some of the examples at the time of perinatal mortality, generally given as deaths per 100,000 births. The low ones were UK and Denmark. Some of the medium ones were Malaysia, Jordan, surprisingly Zimbabwe at that time. I suspect it might have changed. And some of the higher risk ones were areas such as Bangladesh, South Africa, and Egypt. I won't really comment too much about the subgroup analysis going forward because it gets a little bit complicated, but I'll mention it at the end in the conclusion. Obviously, the intervention was the use of magnesium, so a loading followed by a maintenance dose. This could be given either as, I think the maintenance could be given either IV or IM, but the loading was always given intravenously. And they were given a pack as part of the randomization process controlling this. They could continue the treatment beyond 24 hours at the clinician's discretion. This wasn't, however, recorded and it wasn't discussed upon. And if there was an eclamptic seizure, there was a secondary pack that went with the initial pack, essentially a rescue pack, and that one contained kind of the other arm of the trial. So if you were getting actual magnesium as part of your loading dose, the rescue pack would be saline, and vice versa. And this was just to try and avoid any delays in the unblinding process to then give treatment if you thought they needed magnesium. Obviously, as part of the intervention, there was a lot of worries about magnesium toxicity and the safety profiles. They didn't want to have serum magnesium measurements as part of the trial system. That's partly for blinding and partly also because some of the areas where they were doing the trials and didn't have ready access to that. So they used more clinician-based and kind of examination-based techniques, the tendon reflexes, normal OBS, and urine output as well. And I think there was a time frame for them. I think it was every 30 minutes for the reflexes and for the respiratory and urine output monitored hourly whilst giving magnesium. And if the urine output did drop, then you could reduce the rate of magnesium. So it's fairly robust interventions. The randomization process was done mostly by Oxford, and they used a minimization algorithm. Essentially, that was the process by rats is a little bit less random than pure randomization, but it's trying to sort of case controlling you for your subgroup analyses and trying to case match your randomization people that you're randomizing in to try and minimize the amount of imbalance in the data. So although it's not quite true randomization, it actually ends up with more random data than, well, more equivalent data, I should say, than just purely random data. Some areas, however, did not have access to a telephone to call up Oxford, and they just use a standard pack randomization. So they had 10 packs. The first patient would get pack number 1 and it would be recorded, and so on and so forth. So a more true kind of randomization process. The packs were labeled MAGPIE trial treatment. It was blinded to the patients. They couldn't, and the staff, they couldn't tell. They were asked not to measure it, and if they did, they were then asked to report it. And if they needed to be unblinded, they could be. So yeah. I've stolen a little checklist, as it were, from the SGEM, if anyone's heard of them. So it's Skeptic's Guide to Emergency Medicine. And I've put the reference at the bottom here. But I found it quite useful whenever looking at RCTs to see, is this actually a good RCT? Is it answering the question? And when you kind of run through all the questions that you have here for the MAGPIE trial, they all turn back as yes, it was a very well thought out, I think, and with the best of intentions trials. The only things that they did have issues with were, with some of the allocations were because of the range of hospital settings and the range of clinicians, which they couldn't really control for. So yeah, overall, I think it was a very well designed RCT. So moving on to the recruitment side of things and seeing how many they actually got and who they got and where. Overall, about, like I mentioned, about 10,100 women were recruited. The majority of these women actually were recruited in kind of in Africa, in Americas, in the Asia Pacific region, so in those higher perinatal death countries. And a significant number actually were just recruited through the usual PAC system, the randomized system that I mentioned before. And I think this does again kind of play into later on some of the data that they got out, maybe not being quite relevant for some things. This is kind of their recruitment trial little flowchart that they produced, which I think we'll run through quickly because it'll make things a little bit easier. So fairly good split into the treatment and placebo group with regards to recruitment, about 5,000 in each. And the majority of women were recruited prior to delivery, with only about 15% after delivery. And the majority of those who were recruited did receive some form of treatment. Those that didn't tended to not receive any treatment either because there's a clinical decision or an error, with some actually developing eclampsia or delivering prior to the initiation of treatment. A few other reasons which you can read there or look on the paper if you need to. From a follow-up perspective, the vast majority of women were followed up. I think it's something like 99.7%, which is rather impressive. And similarly high rates of follow-ups of the neonates. There were only 5 exclusions in the entire kind of data set, which is really impressive. 3 from the treatment and 2 from the placebo. Obviously, their kids were included. And if you're eagle-eyed and you wonder how have 3 women been excluded on one side, but there are 4 babies excluded, it's because there was a twin pregnancy on that side. And then overall in the analysis, the majority of people who had treatment were analysed as part of the data set, and the majority of birth was a live-born birth. There was some stillborn birth, and I believe there were 120 pregnancies, which were likely to have been miscarriages prior to the commencement of allocation, but they were still included as part of the data set, and they ran both numbers with and without them, and they didn't make any statistical significance. So, is this one not loading? Give me a second, I'll try and get this one to come up. Okay, it's obviously having a problem with them. This is just a subgroup analysis showing kind of where most of the women were. Most things to highlight here as part of it is that the majority of the women who were in the groups, about I think half of them had already received antihypertensives prior to starting. And there was about a quarter of them who were severely eclamptic prior to initiating treatment anyways. So it can kind of obviously sway the results. Moving on to results-wise, this is kind of a nice little forest plot of the results of eclampsia. As you can see in the vast, and these are kind of the subgroups that they're put into. In the vast cases, there was a significant relative risk reduction. I think it's around about 0.4%. 1.5% with regards to developing eclampsia if you received magnesium as opposed to not receiving magnesium. And this was kind of across all countries, but the ones you just need to be kind of careful of here and the interesting things to have a look at particularly are the lower kind of perimortal countries. They didn't have as much of a risk, as much of a significant risk reduction as those higher countries. So yeah, like I said, significantly less. I think it's for treatment you get 11 fewer women with eclampsia per 100,000 women, with p-value highly statistically significant. The numbers needed to treat with severe preeclampsia was about 63. Without severe preeclampsia, that then went up to about 109. And with just later on, one of the criticisms of the paper is actually that the numbers needed to treat for kind of very low risk was about 300 to 400. They ran this over kind of all the other subgroups that they had and found that it was, the effect was consistent with regards to kind of any subgroup that they looked at, really. From a more kind of patient-oriented outcomes, obviously patients will want to care about their mortality and morbidity risk with regards to magnesium. There was no increase, but there was also no decrease mortality risk, and it wasn't statistically significant. And I think this might have been a side effect of them stopping the trial early. All the deaths occurred in medium and high perinatal mortality countries. So none of them happened in, for example, the UK or Denmark. And like I said, it's probably not powered enough to reduce that type 2 error risk. And there were no clear differences in the groups in any kind of measure of morbidity, the renal failure, the respiratory depression, those kind of things that were on the part of the secondary outcomes. And essentially the only thing they really found is the more severe preeclampsia you had, the more likelihood you had of morbidity, and magnesium didn't really change that at all. Again, yeah. From the perinatal mortality side of things, same kind of findings. Really, there was no changes to the risk of baby dying. This very non-significant relative risk increase of 2%, and the effect on death was regardless of severity of preeclampsia or gestation at entry. The only slight caveat they found was that there was a slight increase in perinatal mortality in those who received anticonvulsant therapy prior to trial entry, by which I mean things like benzodiazepines or other of those kind of medications. They did actually write in the report, however, that this could have just been one of those cases of trawling through the data and finding something significant rather than actual significance being there. And then this is the forest plot for that perinatal mortality. As you can see, it's fairly hovering around the relative risk of 1. They're all pretty much crossing except for that anticonvulsant therapy prior to trial. So they had so many outcomes. It takes a while to get through all the results. The other side of things was the side effects profile. I haven't gone into this as much as the rest of them, but I think it is quite important from the magnesium side effects. So at the time, there was a lot of questions about respiratory depression, and although they did find that more women with magnesium had respiratory depression, the actual numbers were still very, very small. So they weren't too concerned about that. There was no difference in the ventilation for the babies of those people with magnesium compared to those without, so none of them required. There was no increased requirement for ventilatory support. A quarter of women, however, had side effects secondary to magnesium sulfate, with the most kind of common, I think it was about 82% of side effects were a feeling of flushing, followed quite a lot by nausea and vomiting and muscle weakness. The kind of common side effects, even if you give magnesium in the intensive care department, you might find. Only 5% of those with placebo had side effects. The experience of side effects was one of the main reasons why women would pull out of the trials. They also found here that the IV route of magnesium tended to be better than the IM route, which was used in some countries, and that there was a small increased risk of cesarean section in those who had magnesium. However, again, how this affects practice, I don't think that would really change your management too much nowadays. There was no effect on any other kind of measures of labour, and there was no usefulness in kind of using it as an antihypertensive. Conversely, quite a few people received nifedipine, and there was no incidences of severe no increased incidence of severe hypotension with magnesium. So from the side effect profile, other than those unwanted side effects, there weren't any that would clinically affect patients. So this is the author's conclusion. I've literally just copied and pasted it here, and I think it's a fair conclusion, which is it reduces the risk of eclampsia. They've said it also reduces the risk of maternal death. I think it points towards that, but I don't think you can say that 100%. And the dosage used in this trial doesn't have any substantive harmful effects, which I agree with, but there is those side effects that the quarter of women still get. So my thoughts on the paper, I thought it was a very well-powered RCT. I thought it was large, 14, recruitment number of almost 11,000 patients. I think they had quite good patient-centered outcomes, partly with regards to morbidity and mortality and eclampsia as well. They allowed for kind of a wide use of treatment, and they specifically stated that this was going to be tried across multiple different kind of healthcare systems, which is both a strength and unfortunately a weakness of this one. They had very good blinding throughout. I think very few patients and clinical members would have known about which treatment they're getting, other than perhaps some of the side effects risk. And I think, for the majority of the outcomes that they stated, they did achieve those. And they did have good safety parameters for this test that didn't require, any costly tests such as running magnesium, serum kind of things. That they were just things you could do at the bedside. So yeah, coming on to the weaknesses, and this also partly from a commentary on the Lancet. I think that 2 months later, after this paper was published, I think the main weakness of this is partly the high dependence on clinicians' belief about magnesium sulfate and recruitment into the trial, and the heterogeneity in the clinical characteristics as a side effect of just running across so many different hospitals. The complications that they had, I haven't really chatted about too much, but even in the paper, they were quite kind of glossed over a little bit. And although there was a reduction in eclampsia, maternal and perinatal morbidity and mortality didn't really change. So I think you have to kind of answer that question of, even though you reduce the risk of eclampsia, does that actually make a meaningful outcome difference to the women involved? It also didn't it did attempt this at the beginning. It did mention about trying to see where the risk benefit balance lies with magnesium, and it didn't really come close to even achieving that. Most of the patients had severe disease, and half of them had antihypertensives prior to starting, with 75% having during the randomization process. And with the subgroup analysis, again looking down, this number needed to treat is almost 400 in developed countries to prevent one seizure. Another interesting outcome was the fact that none of the deaths happened in in well-developed countries, and none of the deaths that did happen were directly attributable to eclampsia. So kind of the bottom line, which I'm shamelessly stealing the name of a certain website from, I think it's quite clear that magnesium reduces the risk of eclampsia, and I think that you can say that definitively as a result of this. Having said that, does the reduction in eclampsia actually mean anything? It doesn't really change morbidity or mortality, but it does reduce the risk of eclampsia. And then there's some further questions as well relating from this trial, which is, what is the effective dose? When is it effective to give it? Should it be given initially by the GP even prior to coming to the hospital if they pick it up? What are the longer term consequences? And some, do you give it only just when you're about to deliver, just prior to delivery, within the 24 hours prior to delivery? A couple of those in the preceding, in the years since, because it's been almost 20 years now since this trial, have been answered. In fact, there was some new guidance on preeclampsia in 2019 by NICE. So they still use the same loading and maintenance doses that were stated in the trial, but they're very much kind of said now that you only give it for a 24-hour period. Subsequent trials have found some skeletal developmental issues with neonates if you give repeated doses of magnesium. Some of the other questions about so that kind of answers the optimal time is also 24 hours prior to giving. With regards to giving it in the pre-hospital setting, certainly in this country, or the primary care centre, in this country, they've kind of disagreed with that, saying that there needs to be, robust treatment, and the patient needs to be in an area where delivery can happen, essentially, which sounds very reasonable. And then other than that, the rest of the management of eclampsia, the only time to really give it is also if you're developing severe preeclampsia, kind of towards the end of the progression of eclampsia, just to try and reduce that fit risk, rather than trying to manage the eclampsia from a hypertension point of view. That's pretty much everything. Very quick tour, I'm afraid. Any questions?
Anyone? Any questions? So certainly my view on that, I think it's an excellent study, really. I think amazingly well designed. The fact they're sort of using kind of countries sort of beyond, sort of Europe, America and Australia is pretty awesome, really. Yeah, I think it answered some really good questions, and obviously it sort of had really impacts on our practice sort of from the day, really. So I don't know what the sort of treatment particularly was like before this trial, but clearly.
So I had a look as part of the kind of introduction side of things, and I think it depended on kind of whether or not you had an American kind of supported healthcare system, was whether or not you use magnesium. And I think outside of the American systems, magnesium was kind of thought to have more risks and benefits. So certainly in the UK, from what I can gather, it wasn't used nearly as much, at all as much as it is now. And it was very much kind of, this brought it into mainline therapy for reducing eclampsia fits.
So the presentation today about the from the Journal of American Medical Association. It was published in 2021, and it is about studies that runs a cohort study between 2013 and 2018 in one of the Canadian cities. So it is about the association of intravenous radio contrast with kidney function. It is a regression discontinuity analysis. So the importance of this study came from radio contrast has been thought as nephrotoxic in the past. A number of recent observational studies found no evidence of the association between the intravenous contrast and the kidney injury. So this study is trying to search for behind this issue. And the objective is to determine if this intravenous radio contrast is associated with significant long-term kidney impairment, and it's long-term, not acute kidney injury. It is designed as a cohort study, about about 156,000 patients that age above 18 that presented to the emergency department during this time with symptoms suggestive of pulmonary embolism have gone through D-dimer, where D-dimer was taken as the variable with a cutoff point which determines if the patient will go for radio contrast or not. So the exposure here is the exposure to the intravenous radio contrast, and the main outcome would be the glomerular filtration rate in 6 months' time. So the result of the study was that for those 156,000 patient or individual with D-dimer positive with mean age of 53 years, 44% of them are men and 56% are women. The baseline of GFR was 86, and the patient above the line or above and below the CT BA eligibility cutoff were similar in terms of confounders. There was no evidence of association of the contrast with the glomerular filtration rate up to 6 months' time. So it's only calculated that 0.4 ml per minute per 1.7 meters square, a reduction in the glomerular filtration rate associated with the exposure to the CTBA. There was similarly no evidence of association with the need of kidney replacement therapy, and the risk difference is almost negligible. Mortality is 0.3%. Acute kidney injury is 4.3 or 95%, just minus 2.7 to 12.9. There are some groups, subgroups of this study, subgroup analysis, consistent with harm among patients with diabetes, but not among those with other risk factors like age difference or like coronary artery disease, like clinical comorbidities. So the other groups was not affected like the diabetic ones. And the conclusion that using the cohort study and analysis that permits stronger causal interpretations than existing observational research were found no evidence for harm affecting the kidney function from the intravenous contrast in the context of CTBA. Again, for the one of the most important radio contrast administration is thought to be causing acute kidney injury, an adverse effect known as contrast-induced nephropathy. A number of recent studies also was searching in this issue, and most of them concluded that the radio contrast is not associated with kidney injury. However, those studies were limited by number of potential bias. First is confounding may result from a baseline difference in risk of developing kidney injury between the exposure group, like patient receiving non-contrast CT used as comparator group and maybe receiving such a scan, they can perceive the bias at high risk of kidney injury. Also, selection bias may arise because of many existing studies look at acute kidney injury rather than the final outcome. So the method of the study here was that they used the regression discontinuity design. So regression or RDD approach relies on the existence of continuous variable, and in this case, the continuous variable was chosen to be the D-dimer, for which the cutoff point determines the eligibility if the patient will receive the treatment or the CT with contrast. Individuals who fall just either side of the cutoff are markedly in different probabilities of receiving treatment, but are expected to have very similar values of their characteristics. And then comparing the outcome in individual just either side of the cutoff, the RDD approach can provide effect estimate for the observational study. So the most common indication for the CTBA is the D-dimer, and they choose a cutoff point about 500. So above 500 will go for a D-dimer to above 500 D-dimer will go for CT with contrast, and then we'll have a serial EGFR test done 7 days after the scan and 6 months after the scan. One more thing is they bought something. They have pre-request for this baseline GFRs. So they did a baseline GFR within 2 hours of the D-dimer result, and if done more than 1 time during the 6 months time, so the latest result to the analysis will be considered. For the study population, so individual above, age of 18 and above, who had a D-dimer measured during the emergency department visit in the Canadian province of Alberta between April 2013 and June 2018. These are the population target, and patient excluded if they did not have a baseline GFR reported within 2 hours of the D-dimer result. So also if they receive a kidney replacement therapy within 6 months before the scan. The outcome and exposure variables. So the primary outcome here is the long-term kidney injury, and measured by the EGFR up to 6 months time after the index emergency department visit. And the long-term kidney function is more patient-centered rather than acute kidney injury, which could vary with many causes. Where multiple EGFR measurements were taken in the 6 months after the index visit, the latest measurement was used. Secondary outcome also is the recipient of kidney replacement therapy or dialysis within 6 months time after the index emergency department visit, or AKI as a secondary outcome. Defined as an increase in the creatinine with 50% from the baseline within 7 days of receiving the contrast, and all cause of mortality at 6 months. The primary exposure was the recipient of the CTBA during the index emergency visit, and additional coverage also may be associated with the outcome included in statistical analysis, which is the age, baseline EGFR, 6, diabetes, hypertension, cancer, coronary artery disease, emergency triage score, and Charlson comorbidity index. A statistical analysis for this, as we said, that the RDD analysis was used to estimate the association between the CTBA and exposure, CTBA exposure and long-term EGFR with the D-dimer, which was running as a variable. For the primary outcome, the effect estimate will be the difference in long-term EGFR, whereas for the binary secondary outcome, it will be the risk difference and the association between the running variable and both the exposure and the outcome were evaluated using local linear regression. Although most hospitals in the study, like D-dimer cutoff was 500, some hospitals used D-dimer cutoff like 460 or 470, and in this case, they used the hospital own cutoff point and readjusted it. All analysis was limited to complete cases. So if a dropped case, it will be excluded from the analysis. As a retrospective study relying on routinely collecting clinical data, there may be significant missing data for primary outcome of the long-term EGFR and secondary outcome of AKI, and they assist whether this may give rise to selection bias by evaluating if the frequency of missing and the timing of the data collection. If there was no association between the treatment group and data missings, as evidences by no change in the cutoff at the end. The final result here was that about 156,028 individuals who received the D-dimer test and met the inclusion criteria during this time or the study period. Patient characteristics, mean age was 53 and men was 44, women about 56% of the study group or the population. Baseline GFR was 86 ml per minute per 1.73 meter square. So the data on the primary outcome, long-term EGFR, was available for about 84,624 patients, which constitute about 54%. And the frequency of missing GFR measurement and their timing did not change at the cutoff point, which contribute to the accuracy of the study. The median time for GFR, for last GFR, was 6 months following the emergency department visit. But 3.7 months is the range. And the estimated effect of the D-dimer cutoff on long-term GFR depicted on this figure 2A. So they made a linear approach where with the small width to validate the result against the result and the variable against a variable which is the D dimer here. In the liner local RDD analysis, there was no evidence of an association with intravenous contrast and long-term EGFR. Just the drop of EGFR of 0.4 ml per minute, which was negligible, which could be attributed to the CTBA exposure caused by crossing the D dimer cutoff. So the sensitivity analysis, including all the 84,600 patients and using global cubic polynomial fuzzy RDD approach, similarly found no evidence of an association between the reduction or the long-term kidney injury and the use of contrast material. The limitation of the RDD analysis relates to the generalizability of the result, because the treatment effect is estimated for those who the dimer value fall at the cutoff point. It may not apply for those further away from the value, like either below the range who received the contrast, or either on the outside the range of the D dimer or far away from the cutoff point. So the treatment effect is further restricted to those at the cutoff who are compliers and those who receive recipient of the contrast enhanced scan. And the conclusion from this study is that according to the group, that the study provides the another evidence that intravenous contrast is not associated with significant kidney injury, further challenging the considerable clinical preoccupation with occurrence of prevention of contrast-induced nephropathy. So my opinion regarding this study was including a larger group of population and over prolonged time, which add to its accuracy, but they did not consider the variability of EGFR, like chronic kidney disease in definition of EGFR and chronic kidney disease in young patient will be different from an older patient. So we can consider chronic kidney disease with a young less than 60 if the EGFR of 75, which was, and also less than 6 years. But if it is less than EGFR will be less than 60 if a patient like 65 and above will consider as chronic kidney disease. So they not mention the exact figure. They just took down the EGFR with 0.4 reduction. The other issue is that they did not consider the other indicator of kidney injury, like urine output, like proteinuria. Rather, they stick to the EGFR result. One more thing is that they did not subclassify the group of patients, like, so it's not the patient will, most of the patient will be with diabetes will have with old age will be with chronic kidney disease, which was not mentioned here, and they did not study the effect of the contrast on a patient with baseline low EGFR. Yeah, that's all from my side.
Thank you very much, Will. Any comments from anyone else on that?
I suppose the main comment I have is, what's the point in doing a study where I think was it the average EGFR was like 89 or something, and then questioning about radio contrast, because I don't know about anyone else, but I've only ever seemed to have problems with people with an EGFR less than like 30. That the radiologists then are getting particularly interested in contrast-induced nephropathy. So I don't know, the whole underlying. It's an amazingly large data set, but how useful clinically is it? Even if they do have a good patient outcome, how clinically useful is it when you're looking at a data set that not a huge number of people, I believe, have an issue with? That would be my kind of biggest question from it.
Yeah, I certainly think that's a very, very reasonable comment. As you say, not many people are particularly worried about contrast if their kidney function is sort of that good, and it is more of the, yeah, if you believe in sort of contrast sort of associated nephropathy, it's where's the cutoff really that we do need to worry. So as you say, Devon, these patients with EGFR sort of above 60, they're probably quite safe from it really. So I'm not sure what this adds, but it is an amazingly big kind of data set to trawl through. But as all these things, it's not a sort of randomized controlled trial, but we're never really going to get that with contrast and AKI really.